thank you everybody for coming to Temple University Japan campus, TUJ. I'm Sachiko Horiguchi, Director of Research here at TUJ, and I'm honored and excited to have Professor Roger Goodman from the University of Oxford join us this evening. Professor Goodman is someone that really needs no introduction, especially for those of you who signed up to join this event. But as many of you would know, he's currently Nissan Professor of Modern Japanese Studies and Warden at St. Anthony's College, University of Oxford. Since last October, he's been based at Tokyo College, University of Tokyo, and as you might know, he's one of the best-known anthropologists of Japan with research expertise primarily in Japanese education and social policy. Professor Goodman has been involved in area studies in Oxford for almost 40 years. He completed his doctorate in the social anthropology of Japan at Oxford in 1982 and has held sort of multiple positions within the University of Oxford. He was elected Fellow of Academy of Social Sciences in 2013 and was President and Chair of the Academic Council between 2015 to 2021. Earlier this year, he was appointed Commander of the Order of the British Empire, CVE, for services to social science. Professor Goodman's most recent book, co-authored with Jeremy Reedon, who's also joined us today, is entitled Family-Run Universities in Japan, Sources of Inbuilt Resilience in the Face of Demographic Pressure, which was published in Japanese as Nihon no Shiritsu Daigaku wa Naze ikinokoru no ka. Other publications include the monographs, Japan's International Youth, The Emergence of a New Class of School Children, and Children of the Japanese State, The Changing Role of Child Protection Institutions. But let me continue on with a little bit of an anecdote, as I personally, of course, have worked with Roger. Professor Goodman has supervised over 30 PhD dissertations, and I was fortunate to be one of these children of this family. And some of these family members are here with us today in person and online. Some of his grandchildren are also here, my students who have joined us today. And Roger was not only a supportive supervisor in my years as a postgraduate student, but also has continued to inspire us all in so many ways as an educator, as a scholar, and a speaker, so he'll make a great speech, and really as a person. And I asked Roger a few years ago about his tips for consistently supervising students successfully, which he's done for these years. And you mentioned that you always have a pattern of maintaining 5 students in a certain number of years, so that there's consistently going to be 5 students. And if I remember correctly, this is partly because you were brought up with 4 siblings, and that you know that having 5 children would offer stability, so that the parenting and supervising will be a little bit of less of a burden because they can help each other. So I hope that we have helped each other. And I thought that this was really interesting point about how to run a family sort of successfully. But this is metaphorical. And today we're hearing about how family-run institutions provide resilience and maybe stability in the context of Japanese medical institutions, along with educational and welfare institutions. So the title of his talk today is Towards Anthropology of Resilience, Educational, Welfare, and Medical Institutions in Contemporary Japan. If you could join me in welcoming Professor Roger Goodman, that would be great.
Thank you, Sachiko, for that lovely introduction. I'd forgotten saying that I like to have 5 doctoral students at any one time. Actually, the argument always was they would look after each other, and therefore I could just get on with my own work. And that's true. That's kind of what happened. I'm going to sit down for this talk in part because I have done my back-in, which is extremely painful, but also extremely useful for my research on the medical healthcare system in Japan. And I will be talking about what this painful episode has taught me about how the healthcare system operates. I wouldn't recommend this as a fieldwork method, by the way, but having happened, it's not been unuseful. So I'm going to just talk a little bit about some of the background to my current project. And as Sachiko-san said, this is actually my it's the first talk I've done on this new research project. I've been doing 8 months worth of field work, so it's very exciting to have an opportunity to just begin to present some of the ideas that I've developed from all the meetings and visits that I've had over the last 8 months to hospitals and clinics in Japan. Let me get a little bit of context, because all research comes from somewhere, and there are two types of work projects that I've done over the last, as Sachiko-san rather unkindly pointed out, over 40 years. There are projects that I've done which have been essentially comparative, on comparative education and comparative welfare. Some people in this room have been part of those big projects, and they've been great fun to do. But essentially trying to understand the Japanese system in a broader context, either an East Asian context or in a East-West context, and also looking into some of those fields and understanding how they compare historically and regionally in Japan. So there's a comparative element that I bring to the project that I've just begun. And the other thing that I bring to it is an interest in what I call the anthropology of institutions. So the three, I don't know what I would call them, monographs that I've done in recent years have all been really looking at Japanese educational and welfare institutions, and particularly interested in how they're organized, how they're run, and how they've dealt with particular challenges over the last 30 or 40 years. So those are the two sort of intellectual, if that's not too grand a word, background issues or background thinkings that I bring to the current project. Now, when I look back over the last 40 years and look back over my research, I realized there are actually two key variables which have driven all of my research. And they're variables that you'll be totally aware of, but sometimes we just need to remind ourselves how dramatic these are just to get a feel for why they're so important. The first variable, of course, is Japan's changing population structure. You'll be as aware of this as I am, but when I did my first project starting in 1980, only 9% of the Japanese population was over the age of 65. Today, well, 2020, 29%. It must be around 30%. That's a different country, right? That's a different society that you're looking at when you've got that change in your population who are over the age of 65. So that's one part of the demographic variable that I've always had in mind. And the second part, of course, is not just the age structure, but the total size of the Japanese population. Again, this is a graph that you'll be very familiar with. Japanese population peaked around 2007 and has begun to shrink. And it is shrinking faster and faster. So last year, 2022, the Japanese population shrunk by 800,000. That is the equivalent of the total population of Yamanashi Prefecture. So it's like taking Yamanashi off the map and saying this is Japan 1 year later. And of course, that depopulation is speeding up, and very soon it will hit 1 million a year decline in the population size in Japan. So there's that demographic variable behind the work, and that's always been, how do institutions respond to that variable? And the other variable that has been behind the work since the 1980s has been the development, is that okay still? Has been the development of what could be called neoliberal political rhetoric. And that means very strong theme, particularly in the 1980s, of the idea that institutions would need to look after themselves. The government would no longer intervene to support institutions that were facing economic challenges. Very strong theme that we relate to, particularly Reagan, Thatcher, and Nakasone in the 80s, privatization of national assets. But the basic idea is the economic market should be allowed to decide which institutions survive, which disappear. The government should not intervene. So that's the other key variable which has been behind all the research projects that I've done over the last 40 years. So just to give you an idea of the previous projects, how those played out. So the first project that I did was about Kikoku Shijo, done back in the 1980s. And one of the puzzles in that project was, why were there so many schools in Japan that received special money or applied for and received special money or funding in order to look after kikoku shijo, i.e. kids who lived overseas when they came back to Japan. There were around 600 or so of these by the early 1980s. And part of my argument, I mean, the main book is about how the kikoku shijo utilized their social class background in order to retain their social and economic influence in society. That was the main argument. But behind that was another argument, which was that many of the high schools in Japan could see that they faced a major problem of recruitment and retention given the major decline in the number of school children. So one of the great things about demography, particularly in Japan with almost no immigration, you know 10 years in advance how many 10-year-olds there will be in the population. So they could see there was going to be this 40% decline. And one of the things that many of these schools realized would be a good way to attract students would to use the internationalization rhetoric, and that could be helped by having kikoku shijo. So therefore they applied to be ukeireko. Okay? So that was the puzzle, and that was a kind of answer of what institutions were doing. The next project was about yogo shisetsu. These are institutions for children whose parents can no longer look after them in care of the state. And again, in the yogo shisetsu, they were facing a problem, a particularly large problem, with the very large decline in the number of live births between 1975 and 1995. Now, you might ask yourself, why was that a problem? Because less children in care presumably is not a problem for society, but it was a problem for them because almost all the yogo shisetsu were private, and most of them were family-run businesses. They were part of large dozoku-kei shakai fukushi hojin, big conglomerations of welfare institutions with old people's homes and so on. And the yogo shisetsu, that was the flagship institution. If that closed down, then it would be very hard to retain the reputation that would allow them to keep open the other institutions. And therefore, they needed to make sure that they had enough children to stay open. And one of the things they did, and I've always had to make it clear, this wasn't a bad thing at all, but one of the things they did was raise consciousness about the issue of jido gyaktai, child abuse in Japan. That only started in the early 1990s. It was pushed by the children's homes, the yogo shisetsu, and as a result, as you probably know now, there's a major concern about jido gyaktai and child abuse, and many children have been taken into care and they're looked after in the yogo shisetsu, and that's why the numbers stayed exactly the same over the last 40 years. And then the last project that Jeremy Breeden over there and I did was about the private universities. And we had a puzzle. We couldn't understand why, when it was predicted so many private universities would disappear, given the incredible decline, 40% decrease over 18 years in the number of 18-year-olds, why didn't that happen? You know, what happened? Why did those universities not close? And I don't want to spoil it completely because you need to go and buy the book and have a look at it. But the underlying argument is they had to stay open, because if they closed, because they were part of large dozoku-kei family-run gakko hojin, it would be hard. They were the flagships. If your university closes, it's kind of hard to keep open the fuzoku, the attached high schools, the hoikuen, the senmon gakko, and so on. And what we discovered was they almost all stayed open, but they completely restructured. And those universities that you looked at 20 years later were there, but they were half the size, with half the fees and half the staff, but they were there, and they had to stay there in order to justify keeping open the rest of the gakko hojin. So those are some of the earlier puzzles that I had in mind when I began the new project, which is about the welfare of the health care system in Japan. Now, the explanation behind those other projects is essentially that family business in Japan is very, very important and very significant. Not a great finding if you know about Japan, because you'll all be very conscious of that. But I don't know you'd be conscious just how significant family businesses are in Japan compared to other countries. So Japanese family businesses have by far the longest lifespans in the world, double that of the US. Or put it another way around, almost half of all the companies in the whole world that can boast a history of more than 200 years are Japanese. I mean, that gives you an indication of the length of the time span of these family businesses. And because you're all Japan specialists, you will understand why this is and how it works. It's all to do with the kinship system, the EA system, the classic EA system, the idea of the extended family, and the idea that in the Japanese kinship system, the number one priority is continuity. Your job as the people currently the head of and members of the EA is to ensure that it continues to the next generation out of respect for the previous generation. And this explains a phenomenon, and anthropologists should never use the word unique, but it's certainly unusual, of adult adoption, which is still very, very common in Japan. The numbers vary a lot, but there have been up to years and recently of up to 80,000 a year of adult adoptions where families adopt somebody to come into the family, to take the family name in order to continue the family to the next generation. Now, you know about this in businesses. Many of the largest businesses in Japan have this phenomenon. There are many, many studies on those. Business world, it's a lot of studies where it happens in the, the traditional arts world, in No and Kabuki and so on. It's talked about in sports, in sumo, all of these things, but it has not been talked about very much in the welfare world, the education world, and the medicine world. But it's because of that EA system, because of this idea of continuity, that over the last 40 years, those institutions I've been looking at, that's why they've been so resilient. And that's the use of the word resilient here, is the idea of continuity because of the inbuilt nature of the Japanese kinship system. So let me move on to the current project, and hopefully I'm going to leave plenty of time for questions at the end. So family-run private hospitals and clinics, Dozoku-kei Irio Hojin, their historical development is remarkably similar to the Shakai Fukushi Hojin, the welfare institutions, the family-run welfare institutions, and the family-run Gakko Hojin. Essentially, in the immediate post-war period, the Japanese government encouraged this sector to expand in order to reduce the need for the state to spend directly on making state-run schools and welfare institutions and medical institutions. And in doing so, they offered very, very generous tax incentives. They made it a very, very good place to invest your money. If you had any money to build a business in the post-war period in any of these areas, it was made quite attractive. Now, these grew very rapidly in size and number, particularly from the early 1960s, when Japan introduced in 1961 the system of universal health insurance. That's a system where everybody in the country would be covered by a health insurance policy, and that their medical care costs would be paid for through insurance companies backed up by the state. So these institutions grew very quickly. They often are described as not-for-profit, and I think that's one of the confusions around these institutions, because they certainly can make profits, and indeed, as we'll see later, some of them can make very, very substantial profits, and indeed, in some cases, that might be one of their primary motivation, is to make profits. But they are not for-profit institutions in the sense that they don't pay dividends to shareholders. So that's the distinction. They can make profits, but they don't have shareholders. Now, these institutions grew very rapidly in the post-war period, but that was fine, because at the same time, the Japanese GDP was growing, and the GDP was growing even faster than healthcare costs. So even though healthcare costs were going up, the economy was growing even faster. And you've now got a situation where of Japan's roughly 8,000 hospitals, and of Japan's roughly, well, it's actually well over 100,000 clinics, 70,000 of the hospitals, and 90,000 of the clinics are private. So you basically have private provision with a state-backed funding system, of which combined, around 80% might be defined as family businesses. Now, why do I say might? I say might because many of these are first generation. So they're new. Therefore, they have the potential to be passed on to the next generation in the family. And we know from lots and lots of surveys that the preference for the owners would be to pass them on to somebody in the family, either a natural heir or an adopted heir. But of course, we don't yet know if that's what's going to happen. So they might be family businesses because we don't yet know what will happen in the next generation. But 80% or so of the vast majority, i.e. 70% of hospitals, 80% of clinics, could be considered family businesses in Japan. And I'll explain a bit later what I mean by that. So my puzzle has been, when I started this project, why is there so little research? Well, first of all, I've always been puzzled, why is there so little research on family-run educational institutions and family-run welfare institutions? And in fact, when Jeremy and my book came out, it was a nice review by a Japanese scholar who said, we need somebody from outside the country to point out this. We all know about it, but it's so atarimai, it's so obvious that we don't think of it particularly as being something that's worthy of study. But I think it's a bit deeper than that, because I think these family-run organizations, in the context of welfare, education, and medicine, are seen possibly as slightly old-fashioned, as feudalistic anachronisms in a world where people who run these businesses are very conscious. Generally, the expressions are about professional management, about separating out families from management boards, where people talk about stakeholders and shareholder capitalism, the independence of boards, and so on. They're very conscious that in most of the world, that's the language when running these types of institutions, and they feel possibly that their institutions reflect a rather old-fashioned view of management. And every now and then, over the years, people have used a word that anthropologists get very excited about. They say talking about this is a slightly taboo topic. It doesn't get better for an anthropologist than somebody telling you that it's a slightly taboo topic. And what they're specifically conscious of is the danger of what psychologists call socio-emotional capital, i.e. personal, family, emotional investment in the institution, leading to scandals, i.e. that the family interest overrides wider professional interests. And that would lead to things like the finances not being very transparent, the appointment of under or unqualified family members within the business to undertake jobs because they're family members, involvement in slightly shady political or other worlds, and particularly family feuds about who should inherit, how they should inherit, how the organization should be run. And the truth is, if you Google family-run businesses and put it together with any of the other words, education, welfare, or medicine, those are the sort of stories that are likely to come up. They are rather grey stories. And the word people use, it's got a slightly kurai image. It's got a slightly grey image in Japan. And you go onto magazines like Bunshun and Factor, they're obsessed by these family-run feuds, family-run businesses, feuds and breakups, and so on. Okay, very useful if you're doing research. But it's an interesting indication about how it's generally seen as a rather negative, slightly scandalous world. So as I say, there's been a lack of research in the education, family-run business, education, welfare, but also in the medical field. So my research questions have been, given that we now have seen there are so many medical institutions are family-owned, what are the implications for healthcare outcomes and healthcare costs? Implications for employment practices and institutional stability. And at the end, this is me as an anthropologist pushing the boat out a bit, because we're not great at dealing with policy implications, but what might be the lessons for systems elsewhere? How might we look at our own systems differently in the light of what we can see in the Japanese system? So, as I say, I started this research in October last year. Been doing about 8 months. So just think of me as a doctoral student 8 months into their first fieldwork project. Go gentle on this project. I'm still trying to work out a lot of what I'm looking at. But I've been pretty busy. I've had meetings all the way from, well, I better not name names, but from very, very senior politicians through policymakers, a lot of academics who are working in this field, medical associations, of which there are numerous associations, a lot of time with the people who make the equipment, with pharmaceutical companies. But in particular, I've focused on interviewing and spending time in private hospitals with the owners, the directors, not necessarily the same in those cases, and the doctors, plus in comparison, for comparative work, public sector, doctors, nurses, support staff. And I've also had a lot of reviewing of, and I'll show you some of this later, the secondary literature on hospital management. And I've also been doing participant observation. Now, that's a tricky issue because I'm not medically qualified, and there are ethical issues about pretending to be medically qualified. And there are all sorts of issues around patient data and so on. But I've ended up doing rather a lot of participant observation, not consciously, but unconsciously, through being a patient in Japan. And I suspect most of you have been patients in Japan, and I suspect most of you will have stories that you can share. But I can go on and give you some examples of those. So let's start with an overview of the system. And most of this you should know. Japan has world-class health, and it has a world-class healthcare system. The two are not necessarily connected, indeed. Some people might argue Japan's excellent health may be despite rather than because of some elements of its healthcare system, and that's a debate that we need to bear in mind. But the population health is excellent. Life expectancy, as you all know, is just about the highest in Japan, and we could talk a long time about how that has come about. For women, it's just over 90. 91 now is life expectancy for girls born in Japan. It has amongst the lowest rates of infant mortality. And it has, and this is perhaps a really interesting figure, it has less days lost officially, work days, through ill health than almost any other advanced industrial country in the world. Now, you might say people go to work when they're ill, but nevertheless, that's a measure of health in the population. In terms of the healthcare system, you'll be well aware of this. It's got very regular, very low-cost health checks. I got my letter this morning from Bunkyoku telling me that I can choose 2 different methods to have my stomach cancer checked, both of which sound rather unpleasant, for free anytime over the next 8 months because I'm a certain age and my birthday is an even year rather than an odd year, because that's how they divide it up. It has universal health insurance. Everybody is covered by health insurance in Japan, either through company health insurance up to retirement age, or through the national health insurance, or through the long-term credit insurance scheme when they get over a certain age. And the premiums people pay for their health insurance is linked to the income of their previous year, including the aged people. So if they suddenly sell a house and get a larger income, then premiums will go possibly up. But nevertheless, it's a very egalitarian system. And similarly, you've got totally egalitarian access to health providers and health treatment. Anybody can go to any doctor, any clinic, any hospital, anywhere in Japan, anytime, and they will be assured of getting treatment. And perhaps most interestingly, if you come from a UK perspective, there are no waiting lists. Now, there might be waiting lists for a particular doctor at the University of Tokyo, who everybody thinks is the best doctor in the country for a particular illness. He might have a waiting list. But if you want to go and see somebody else to have that issue dealt with, there won't be a waiting list. And maybe for some mental health issues as well, there might be some small waiting lists. But otherwise, there are generally no waiting lists. And you get the same treatment wherever you go. That's the point. There are marginal differences you can make. You can pay for a private room, possibly in a hospital. There are 1 or 2 areas that you could pay a tiny extra. But in general, you will get the same treatment wherever you go, however rich you are. Now, Japan has really interesting cost control mechanisms on its healthcare system. This has been one of the things that I spent a lot of time looking at today. So in a clinic, if you go to a clinic, I'm sure you're aware of this, if you've been to a clinic, you get a printout at the end, which will tell you how each interaction that the doctor had, how many points it scores. Those points all added up, and you will probably end up, if you've got a national health insurance, you'll end up paying 30% of all those points. So the points are times 10, because they're each 10 yen. You pay 30% of that final amount. Those points are reviewed every 2 years. So we just, June the 1st, the new point system will come in order to just check whether people are getting the right, whether people believe doctors are getting the right number of amounts, payment for the different things that they do. Doctors will submit to the insurance companies every single claim. So you pay your 30%, you still co-payment and go, but the other 70% they will claim from the insurance companies. And those will all be reviewed by local committees of fellow doctors who will look at them just to check that the diagnosis is in line with the treatment. And if they're worried about any of it, they will send it back to the doctor for review. And in a small number of cases, they won't pay it. So the doctors will have to cover the full 60%, 70% that the insurance company doesn't pay. So it's been very, very closely monitored. That review takes place every 2 years of all the fees. The new book's about to come out. The last one was 1.6 kilos. That's how big the book was that has all the instructions over the fee. The latest one apparently is 1.8 kilos, okay? I'm kind of thinking of buying one to take back to the UK to use as a prop in lectures, but I'm not sure I've got the luggage allowance to take it. So every 2 years that's reviewed, it comes out and so on. And it changes quite dramatically. So on June the 1st, for example, the amount of money that doctors will receive for each consultation for dealing with what they call lifestyle illnesses, so that's things like cholesterol, blood pressure, diabetes, will be reduced by half. The argument that the Consejo has made is that doctors got a lot of extra money during the pandemic, therefore they should have large savings and therefore they can afford to take the hit on that amount of money and it should come down. But every doctor I've spoken to over the last few weeks said, well, what we will end up doing, consciously or unconsciously, is just setting up more tests because the amount of money that you get for the tests has stayed the same and therefore I'm pretty sure they say that you'll see some trade over there. And the total envelope, I should say, was set by the Ministry of Finance for those negotiations. And they gave a flat budget figure for the negotiations that took place at the end of last year, which means, given inflation, there's actually been a 2% cut in the healthcare system here. There are not many advanced industrial countries at the minute which are seeing healthcare cuts. And according to the OECD, Japan's healthcare figures is roughly 80% of the UK age-adjusted rate. I could talk about this at length. This is highly contested by health economists, but that's the official figure. Now, the system in theory is one where the payments are made jointly by you, the patient, say 30%, and the rest by the insurance company, 70%, out of your premiums. But for many, many years, the amount of money paid into those health insurance companies has not been enough to cover all the costs, and the shortfall is met by the government. And that at the minute is up to around 35 to 36% of all the healthcare costs. And this is a big issue about how you're going to sustain the system into the future. But what it means is the Japanese system is often described as Bismarckian. That's this system of payments through health insurance companies and individuals. It's not really, because it's got that government element, which is what's called a beverage system after the UK system. It's a combination of a Bismarckian and a beverage system. A bit technical, but I think it's an important point. So the sort of institutions that I've been looking at, I'll give you just two examples. There are two main types of private family-run institutions in Japan. One are sole practitioner clinics and hospitals, i.e. one owner, one family owner who passes on from generation to generation. And the other one is large multi-hospital corporations, what I call medical, social, industrial complexes with integrated care institutions and thousands of employees. You've either got very small clinics or you've got hospitals and which are part of very, very large conglomerations. So two of the case studies that I've been doing, and I cannot tell you how grateful I am for the help that I've had from the institutions. One is of a little clinic up in Saitama-ken. It's the 5th generation. There's been one adoption in those 5 generations. It's got a single doctor practice, started in the Meiji period, 7 employees, part-time public sector doctor, I'll talk about that later, who comes and works 1 day a week out of a public hospital, nurses, radiologists, lab technician, 2 receptionists, and his mother, who's also a doctor, occasionally comes and helps out as well. The other type of case studies I've been looking at are one of these huge conglomerations. So the one I'm particularly interested in is the 11th generation, 350-year history, 3 adoptions, family-run corporation. It's got its headquarters up in Chiba, and it's got 5,000 employees. And it looks very much like a traditional Japanese company in terms of lifetime employment, company unionism, seniority promotion, and a culture of making people feel like they are in a extended family, just like the company culture that we have talked about for many, many years in big companies in Japan. The governance and the finance of these institutions, generally speaking, the hospital clinic owner also serves as chair of the board as well as being director. Not always, but general covers both of those. So they have complete management control over this institution. And as I say, their income comes through health insurance programs and patient co-payments. So let me give you two examples, which I think are interesting exemplars of the way the system actually operates, so the logic behind it. So this is my first one. This is why I'm sitting down. Don't do this one. This is the trapped sciatic nerve one. This is a very bad idea. So I trapped my sciatic nerve. I think I knew exactly what I'd done some time ago. What do? I can hardly move. It's very painful. I crawl out to go and see a doctor. My first problem is deciding what type of doctor to go to. I assumed I just need painkillers, and I assumed painkillers was a NICA, an internal medicine doctor. So I crawl along to the road down to the local NICA clinic, who say, you don't want to come and see us. You need to go and see an orthopedic surgeon, Seikei Geka. You need to go and see an orthopedic clinic. They can look after you. Because they could see the way I was walking. So I said, well, where's one of those? And they said, are you kidding? You live in, this is Hongo, or Chanomizu, Yushima. There's an orthopedic clinic every corner. Just walk outside. Those are the kanji, walk outside. And of course they were right. Directly across the road was an orthopedic clinic. I walked in, did not look very promising. I had to go past, it was at the back of Dutour, there was a lift. There was a Dutour coffee shop. At the back of it was a lift. Went up to a clinic on the 6th floor. It just said, I won't give you the name, but so-and-so's clinic on the 6th floor. Could have been anything. But it was, I walked in there, it was a clinic. I definitely was a clinic. I walked in. There was must have been about 10 people I could see waiting, I assume, to see the doctor. I registered to see the doctor, sat down. The doctor saw me. It was certainly less than 15 minutes, probably more than 10 minutes, say 12 minutes. Looked at me, pretty obvious what the problem was, sent me to the room directly next door to do x-rays, did 4 x-rays, radiologist came in. 5 minutes later, I'm back in there with the doctor. She's got the x-rays up on the screen. She looks at them and says, one of your discs has decayed. I think that would be the translation. It's an aging problem, thank you. And it's trapped your nerve. She said, that will be painful. I said, it is. She says, I can do 4 things. I will give you a steroid injection, and I will arrange for you to be fitted with a lumbar belt, and we will do some electric therapy treatment on where it hurts most. I've got a TENS thing, and I'll give you some, what she called in English, very strong painkillers. So go down to the therapy, go out now to the therapy room. So that all took about 3 minutes, okay? Go to the therapy room, line up. So I line up there, there's about 8 people. Within 10 minutes, I'm lying down, they give me the electric treatment. She has to give the steroid injection because she's the only one qualified to give injections, although there are all these nurses there. Fit belt, go to get the prescriptions. From the time I went in to the time I came out, it was 1 hour, 5 minutes. Go across the road, register at the nearest pharmacist, they're everywhere. And I get and it cost me, what did I say? It cost me there 4,200 yens. The medicines cost 600. And then I do follow-ups every time, it's 600. And then after 6 weeks, because it still isn't better, she's just sent me for an MRI. Okay, and that cost me 7,000, whatever it was. Now, I've just given you below what I've talked to a number of doctors in the UK. This is what might happen in the UK, okay? Don't take this as gospel. Depends where you are, it's very different, but you've got a very different system. UK's got a primary health care system, you've got to go and see your GP because they're the gatekeeper. In the UK at the minute, it takes 3 to 5 days to get a GP appointment. Oxford's good. They could give me the painkillers. They probably would have given me an opioid-based painkiller, which you don't get very often in Japan. We could talk about that. Then they would have said, come back a week later, see how you are. I'd have gone back a week later, still in pain. They'd have said, let's make an X-ray appointment. Varies where you are in the country, but it can take up to a week to get an X-ray appointment. It can take up to a week for the X-ray, bizarrely, to go from the X-ray appointment back to the doctor. You'd then go back to the GP, who then would look at the X-ray and say, this doesn't look good. You've got a decayed disc. I suggest you go and see an orthopedic consultant. And at the minute, it's taking 10 to 12 weeks to get an appointment with an orthopedic consultant, if you still needed it. Because, of course, by that time, many people, this would have cleared up. You'd have given up. You wouldn't have gone. You wouldn't have used the resources, okay? I'm not saying that's the policy, but that's what happens in practice. Second case. I'm a pretty healthy person, by the way. I really, really am healthy. This has all been very surprising, but not unhelpful. So a second thing, this actually happened a few months ago when I first arrived. I began feeling rather dizzy suddenly, a feeling that I'd never had before. So I go to my employer's healthcare desk. There's always somebody on duty. There's a doctor there. It's his turn to be in charge. Cost me 400 yen every time you go. He didn't look at me at all. I said, I'm feeling dizzy. He sent me straight for an MRI. In Tokyo, there's a company called Tokyo Medical Scanning. It's got MRI machines all over Tokyo. You ring them up, and the MRI, I think it was 2 hours later, did an MRI, go back to them, and they say, well, that's all clear, that's good. Maybe your problem is a neck problem. So they send me to a neck specialist, and the neck specialist says, I'm going to send you for another MRI. So I go back to an MRI place, the same place, actually. They're quite surprised to see me 2 days later. Have a second MRI. This one's only half the price because you can only charge 50% for 2 MRIs in 1 month. And then I sent me back with that MRI to another neck specialist, still all clear when he looks at it, finally refers me to an ENT consultant in the hospital who does some hearing and other tests, moves my head around a bit, and confirms I have something which is called benign paroxysmal positional vertigo. All it is some of the stones in the inner ear had moved, and I was having balance problems as a result. When I talk to GPs in England, they say we see that every week. We would have known almost immediately what that was. We'd have done some very basic tests, and we would have told you what you were told eventually after 2 MRIs and 4 visits to different types of people in Japan, that it would clear it up by itself. And by the way, if you wanted an MRI, you'd have to go privately, and it would cost you the equivalent of 155,000 yen if you could get one, just out of interest. So that was 2 experiences. What do they tell us? Well, okay, some of these are things that won't surprise you. Japan has the world's highest use of medical equipment. I think we've just seen that. I've just had 3 MRIs done in 8 months. Okay? It has 5 times the OECD average of MRI machines, 5 times the OECD average of CT machines. The smallest clinics have MRI machines. And we can talk about that. But I've been to little clinics. The one in Saitama that I'm doing my research at has his own MRI. It's on an 8-year lease. He has to have a radiologist to run it. And he has calculated he has to do at least 4 MRIs a day in order to cover his costs across the whole 8-year period. The second thing that is noticeable about Japan is visits to physicians are twice the OECD average. I've done my bit to make that figure here. But interestingly, the number of doctors in Japan is only 0.7% the OECD average, way down on the OECD average. And as for female doctors, that's only half the OECD average. Now, we could talk a little bit about that figure because it's very interesting why Japan has so few doctors compared to other OECD countries. So if you've only got almost half or you've got 0.7% or 70% of the doctors and you're going twice as often, each physician is seeing 3 times as many people as a physician is on average in OECD countries. They see 3 times as many people. On average, in Japan, every clinic is seeing 40 patients a day. Depends where you are. It depends what your speciality is. Depends what your overheads are. In general, it's calculated you need to see at least 35 patients a day to cover your costs. 40 is the average, 60 you're making a profit, 80 you're making a nice profit, 100 you could be making a lot of money. And I've met people 120, even more, seeing that number of patients a day. The fees for services thing, which I've just talked about, which I've forgotten, I've written this down here, directs the kind of interventions that doctors are likely to make. So you get a lot more therapy. One reason you get more therapy is that there is in each, I think it's prefectural, but it may be a local area, a figure that has been decided by the insurance companies and the local medical association about what the average charge per patient in a clinic should be per month. So how much each person should be costing. It's around 1,200 yen. It's quite low. But in order to bring it down there, you do a lot of therapy, because every time I go and do my electric therapy, it costs 300 yen, and that's the way of bringing down the average. So you're pushed in certain directions, more therapy, more tests, and certainly more prescriptions. But you're pushed away from surgery. Surgery does not pay well, both to recommend it and to do it in Japan. It has lots and lots of data, so the surgery will be put off unless there's absolutely necessary. And maybe that's not a bad thing, whereas in other countries it'll be done much more quickly. The other interesting thing is that doctors in Japan have no specialist certification systems. Once you have qualified as a doctor, i.e. you've done your 6 years of medical training and your 2 years of internship, you can call yourself a doctor of whatever you want. You can set up a signboard in any specialist subject that you want, except for general practice. That's not allowed. But you can be a doctor in whatsoever. Now, there are specialist licenses that you can get. You can get the credentials, and I'm glad to say that many doctors do, but you don't have to. And equally interestingly, once you've qualified, you're a doctor for life. So if you stop practicing for 20 years, you can come back after 20 years and start all over again without needing to re-qualify. Again, I'm sure that doctors do come back after 20 years, do go through programs of re-qualification, but they don't have to by law. So it's a self-accreditation system. But the most conspicuous difference in Japan is between the public and the private healthcare systems. This is really quite dramatic. So in the public sector, for example, well, actually, I could put it a different way. Why don't we talk about the training? So Japan has a large number of about 70 medical schools, of which I think the majority, around 40, are private and 30 are public. The fees for the public ones, as with the universities, you'll know about this, are much, much lower. And how should I put this? As the competition to get into medical schools goes down, the fees goes up. Okay, this is what economists call the law of inelastic demand, because when you get to the bottom of the system, and there's only one medical school left, if you want to become a doctor, they can charge whatever they want. So the least competitive medical school in Japan, their fees are 13.5 times higher than the most competitive medical school. Okay, and that's explained by this law of inelastic demand. But there's also a huge difference between public and private pay. Doctors in the public sector, on average, are earning roughly 60%, 65% of doctors in the private sector. And particularly if you compare them with doctors who own their own clinics, it's almost half what they're earning. The result is that most doctors in the public sector need to go and do arbeito at least 1 day a week in the private sector, in the clinics or in the hospitals, which will often increase their income by up to 40% just 1 day a week. The question is, in that case, why do they stay in the public sector if the money is much better in the private sector? It's partly status. The status of doctors in national hospitals is much higher. But it's also because they say that's where you get the most interesting work. That's where you get the most acute cases. That's where you get the best resources for doing research. That's where you get the challenge. And so. But if you do stay in the public sector, there's another thing that kicks in, which as an anthropologist I've found fascinating, is a system of the university from which you graduated very largely determining where you will work for the rest of your career, known as the ikkyokusei, or the medical department system, where if you graduated from this section of this university, they will very often be determining you will be working at this hospital and you will go and work there. And if you don't go and do what we say, you'll never be able to come back and work at the main hospital, which is where you probably ideally want to work. It's very interesting, Mr. Kyokusei, because officially it disappeared 20 years ago, but it just comes up in every interview and every conversation as part of the worldview and part of the experience of doctors in the public sector. Oops. So that's the distinction between the public and the private sector. What is it distinctive about the family-run institutions? One way I've discovered that you can find out a lot of its institutions are through these wonderful Q&A books. And one of the wonderful things about Japan is if you are involved in any sector, any institution, there will be a market out there of Q&A books about how you should operate in that. And this is huge literature. I've got just a few of the books that I bought. I have to say, I've got a research budget at the University of Tokyo, but I have to order it through a central office. They're very, very puzzled by the books that I've been ordering this year. I think they think I must be running a private clinic on the side, because I've got lots of books about how to pay less tax when running your clinic, how to do all sorts of things. They've never asked. They're very polite. They just hand over the books. But I think they must be a bit puzzled by my choice of literature. So let's just have a look. So the book on the left, How to Turn Around Your Clinic. It's making the most of 4 management resources, okay? These are just the headings of what's in that book. This gives you a wonderful clue of some of the concerns, assumptions, and priorities of people running private clinics and private hospitals. So the question here is, first of all, it's assuming that most clinics or many are operating at a loss. The financials are very complicated. There are massive advantages tax-wise to make it look that you're not running a surplus. So many clinics and hospitals take out very large loans in order to push their current account into either balance or even possibly into the red to avoid tax. What are some of the things? Is it advantageous to open a business through succession? So this question of succession comes up immediately. And this is very interesting because this is still perceived to be the norm, that if you have a clinic, you'll pass it on to somebody who you consider to be a successor. The next one's a bit weird. Can luxury cars be included in my expenses? Except that you can include anything, pretty much, as your expense, if you can justify it as an expense for running. I'm careful what I say here, but it's quite interesting what people do include and talk about in their expenses. You sometimes need an overseas research institute to help your clinic staff develop their skills. Might be quite nice if it was in Hawaii, for example. There are all sorts of ways that you can think about laying things off against your expenses. Advantages of having your spouse work, a very common pattern. Reducing the tax burden through medical incorporation. That's been becoming an ideology, incorporating yourself. Not everybody incorporates themselves. Some of them prefer just to be in unincorporated private hospital, but there are big tax advantages to incorporating yourself. How to avoid inheritance disputes. The more medical equipment you have, the more you can meet the needs of the patients. Can problem staff be fired? Why can't our advertising work? And I love this last one, how to deal with monster patients. Okay, not an expression that I'd heard before. So the last slide. I've just about come to the end of my hour. So what does this all mean? What's going on here? Is there anything out of this system that possibly other systems could look at and think about? So Japanese system is often criticized for being incredibly fragmented. Remember, I couldn't decide which clinic to go to when I did my back-in. Remember, I got sent to a cardiology unit, a neck unit. I still wish I knew where that neck unit was. I don't know what section it was in before I got to an ENT unit. The insurance programs, there's 4,000 different insurance programs in Japan with slightly different cover and slightly different premiums. There's a huge number of hospitals in Japan, 8,000 for a country this size compared to any other country. The number of hospitals is way over the OECD average. And there's way over in terms of these clinics. And these clinics are always one-person-owned clinic. You don't get partnership clinics. You may get a building with lots of one-person clinics in together, but you never get several people running a clinic, owning a clinic together. And then you've got this, because it's so fragmented, it means that people can keep changing which doctor they go to. If they don't like one doctor, they go to another one. Doctor hopping. And it's so fragmented that this doesn't get picked up by the insurance companies that pay twice, or 3 times, or 4 times. Okay? There's no gatekeeper system. You can go to any doctor that you want. And this, there's no doubt about it, this fragmented system can lead to very different health outcomes depending on where you live and what's available. So if you look at the number of doctors per 100,000 by prefecture in Japan, the differences are incredible. There are twice as many doctors per head of population in Kochi as there are in Saitama. There's roughly 70% more doctors in West Japan than there is in East Japan. There's a huge variation in the number of doctors in different places, and there's historical reasons, huge differences between rural and urban, huge differences in provision of what's on offer, and huge differences in what kind of general care that you get. But, and this is where I think I found it interesting, if you are in a urban area, and don't forget, I'm in the area where there's probably more, where I'm living at the minute, more clinics, dentists and pharmacists per head of population than anywhere else in Japan, I'm guessing, because there are so many medical schools around the Hongo or Chanomizu area. If you're there, there is great competition. Those clinics have to compete. That's why they often will have to find their niche market. That's why they put things up on their board to, if they find there's a gap in the market that's complementary to other clinics. But they've got to be quick to keep you. Okay? I was seen in 12 minutes. I don't know how that happened, but I was seen in 12 minutes. It's about quantity as well. The speed with which doctors get through. The choreography, I would love to talk about. Watching how the doctors are so clever at moving you on through the process that you don't spend a long time with the doctor. So they need to compete to attract and keep patients. And competition can drive up service. Okay, this goes back to the neoliberal market idea. And that's why they've all got MRI machines, because if that one's got one down the road and you haven't, you're not going to get any patients. Is that efficient? That's another question. But it definitely drives up service. There's no doubt about that. If you compare that with the NHS system, which is the one that I was comparing it with before, the individuals, and every individual in the NHS system works extremely hard, individual departments, they're only focused on their own role because it's a national, universal system. They have no sense, I'm absolutely sure about this, of their own interactions, their own actions, what that has on costs. Therefore, there's very little cost incentives for them to change their practices, to think about what they're doing. They don't have the fee for services structure, which is getting the doctors. Many doctors I talked to said a little bit of your brain all the time is conscious of what the cost structures are while you're seeing patients. Of course, you're focused on the patient, but you are conscious of the cost structures and how those are changing. So Japan's medical system is just a thought to end with, because I just wanted to be a little bit provocative. I think it probably does constrain stronger incentives, and it certainly has stronger control structures over its costs to help improvements than a centralized system like the NHS. But I've talked for an hour, and I should stop there, but thank you very much.
Thank you very much, Roger, for this really fascinating, I think, insights that you gain from different, perspectives, both as a patient and also talking to doctors. So I'd like to open up for Q&A and discussion. Because we're recording this event, okay, and I want to warn you that you're going to be recorded if you're going to ask questions. There's a microphone we have with Nico here. So if you want to ask questions from the room, okay, please raise your hand, and then we'll bring a microphone. Okay. For those of you on Zoom, if you could raise your hand or put your question on chat, I will respond to them as well. If you could kindly introduce yourself a little bit, okay, when you speak up, that would be appreciated. So any questions, comments?
Hi, I'm Karen Thornber. I'm a professor at Harvard where I teach medical humanities primarily to undergraduates. I have a couple hundred of them a year and do include a couple weeks on Japan. I'm primarily a Japan specialist. So it's really wonderful to meet you, Roger, and thank you for this amazing talk. My question concerns mental health care in Japan, and I wonder if you could say a few words on the nature of these family clinics. You know, what kind of, I mean, you spoke of your own experiences with illness. Where does mental illness fit in to this bigger picture? Is it treated differently in these family-run clinics? I'd just love to hear a bit more. Thank you.
Yeah, the short answer is I haven't got into that at all. I'll be very honest with you. So I've been focusing on, I guess, it's a very good question, why I haven't come across that. I suspect it's a slightly, I mean, there definitely are family-run mental hospitals, if we're allowed to use that expression. I'm not quite sure that's the correct expression. But, and of course, there have been, over the years, many, many scandals over those institutions. You know, most famously in the 60s and 70s, Takemi-san, who was the chair of the Japan Medical Association, had this famous quote talking about the doctors of those, the owners being, I think, stock herders, I think, is the very famous expression that he used. This is the head of the Medical Association himself talking about the appalling way in which people were treated in those hospitals. So I'm assuming things have improved greatly. I kind of haven't gone there, partly because I know other people are working on it. So Kitanata Junko, who you will know, and other people are kind of working in that area. But it is interesting, I've only been to one hospital chain, which was up in Fukushima, where they had 4 hospitals in the family network, one of which had 200 beds for patients with mental health issues, was the way they described it to me. All the other chains that I've been to have not had that. And so I suspect that it's a slightly specialist area that is possibly run separately. But it is intriguing that I haven't come across it in the course of the clinics and hospitals that I've been to. And yeah.
Yeah, and none of the folks, I mean, because you interviewed a really impressive range of folks, and that nobody brought up mental health.
No,
that's really
it's interesting in itself. That's a really good point. That's a fair
you.
point. Thank you.
Thank you, Roger, for the great presentation. I particularly enjoyed your field work, participant observation of the medical system. But I just wanted to ask whether you have kind of run into this. You've been talking about this, this national medical system, which is egalitarian. But I just wanted to wonder if you have ever kind of run into this, how this, this independent treatment. So the treatment that doctor sometimes recommend the patients to take, with, that will not be covered by the national insurance. So and how that will kind of impact the management of the private manager, because the reason I ask is that I have another participant observation of the medical. So I had a bad tooth decay, and I visited the local dentist, and he diagnosed that this need a root canal treatment, and he kind of suggested that, or I kind of also searched for the good root canal treatment doctor, and the website, some people says that if you really want to get a best treatment for the root canal, you don't visit those random dentist who don't use the national insurance system. Just visit the dentists who are professionally trained in the U.S., specialized in root canal, and most of those dentists do have their office in Japan, but they only take the patients who are willing to do it independently. And so, so I think that there should be kind of area that is outside this national healthcare system, which presumably appeared to myself as lucrative going with a national healthcare system. So have you ever heard of that area?
Yeah, so this one I can answer a little bit. First of all, thanks for sharing your own experience. I have to say this is a project where everybody has got something they can share. I thought working on universities was pretty good, but actually a lot of people left university a long time ago and have kind of forgotten about their university experience. I haven't met, well, there is nobody in Japan who has not got something to contribute about their own health narrative and their own health experience. So I've never been short of people to get data from. But there are very, very small segments of the system that are private. I did actually, by chance, do an interview with a doctor outside the health insurance system. He told me that only 2% of all dentists in Japan are outside the health insurance system. He was one of them. He, you know, I think, it was again down in Chanamizu, in that kind of area. There's such a demand, and there were so many dentists that he felt that he could do that. There were not many things outside the health insurance system. Plastic surgery is one. That's why there's so many plastic surgeons. Childbirth is outside the health insurance system, as you probably know, but it's generally covered by your local city hall, and therefore that tends to put some kind of constraint on the cost. Abortions, of course, are not covered, so people have to go privately for them. But there's remarkably little outside the health insurance system, and therefore people are pretty much tied into it. There are clinics for Westerners, Western doctors. Some of you probably know about this. They're outside the system, but they can only treat people who aren't on the insurance policy. But these are pockets. I think they're pretty small. I've been struck by how comprehensive the comprehensive system is, and how people get a remarkably similar level of treatment wherever they go, at exactly the same price. The price is fixed. That's pretty tough for doctors in Tokyo, because of course their overheads are much higher, and there are all sorts of questions about that. But the cost will be the same, and the treatment's pretty similar. There's not a lot you can do to buy special treatment. I mean, in the old days, if you're having surgery, you'd put a little bit of money in the doctor's coat. I've only found one doctor so far who's admitted that still happens, a surgeon who says that people would just put in his white coat a few thousand yen in the hope that they'll get special treatment. And I said, what did you do? He said, well, what could I do? It's too embarrassing to give it back, he said. The doctor in Saitama gets vegetable boxes delivered regularly outside his clinic, more than he wants, but which is the kind of local custom. But generally, you can't buy better service. Yeah.
Thank you very much.
Thank you, Roger, for your interesting research. I'm Aya Nishizono Maher. I'm a psychiatrist. I've been a psychiatrist for 30 years in Tokyo. Yeah. I know Oxford and Edinburgh, so I can compare NHS and Tokyo system. I know tradition of family business, dozoku-kei, is strong in Japan, but still I think there has been a big change. I've seen big change in the practice. The medical schools are much more difficult to get into compared to Showa Jidai. So it's very difficult for doctors to force their sons and daughters to go into medical school. In 1970s, they could do that. If you put 1 million yen, you can get 1 point kind of in the entrance exam. That happened, but now it's impossible. So it's very difficult, and doctors don't seem to force their sons and daughters to go into the business. They employ someone to inherit the clinic, not necessarily adopting the person. And I observe younger people are opening their own clinics compared to before. There's still EKYOK system, but it's much weaker now. After graduation from medical school, they go into any hospital for a training, and they don't need their professor's permission to open their clinics. So with young people, it's a trend of young entrepreneurship, and we do have specialist accreditation. So after graduation, after about 6 years, you get specialist accreditation. So after acquiring that specialist, like psychiatrist Senmon-ii or surgeon Senmon-ii, that's your, you can open your own clinic. So people, younger people are opening their own clinic, I think. So psychiatric clinics, there are lots of new psychiatric clinics outside family business. Yeah. The psychiatric hospitals some of them are family run at the moment. But so there has been a change since Showa Jidai, I think.
So I'm sure that's true. I have no doubt that's true, and that's what most people start by saying. But it depends what... I'm surprised, and I'll give you some examples of how much of that system is still there. So rather than it's changed, but I'm quite surprised how much there. To give you some examples. So as you know, the family-run clinics and hospitals, the main body that represents them is the Nihon Ishikai, the Japan Medical Association, who are very quite conservative organization, very reluctant to have too much change. And the reason why there's only 70% of the OECD average of doctors is the refusal of the Nihon Ishikai to open up to more doctors to protect the interests of the current doctors. So they're really worried, for example, about succession. And they make exactly the point that you do, that these days, there aren't many hospitals and clinics that have got succession. And they keep doing surveys to try and prove this, and they're worried about what's going to happen and so on. But they say things like, I just found the latest survey that I got sent a couple of weeks ago, and it says something like, where was it? So the average age of retirement for a one-person clinic, the owner, is around 76. That's the average age. So many of them are well into their 80s and some into their 90s. But it says here 40% of respondents in their 70s, so this is a survey of all clinic owners, and 55% of those in their 80s have nominated successors in place. So they're saying, oh my goodness, these people only, it's only half of them. I'm going the other way around. I'm going, that's amazing, because those are the ones already that got nominated successors. It doesn't mean to say that their other ones won't come through as well. So I think it's quite a strong tradition still. And I think the adoption, but I totally agree with you. It's much more difficult because not only does your child need to decide they want to become a doctor, they need to become a doctor in your speciality, and they need to become a doctor willing to take on a large amount of administration and responsibility. So that's quite a tough call. So I find it amazing that still around 60% of these clinics do have a nominated successor. So anthropologically speaking, I think that's the interesting question. The ikkyokisei, that's really interesting. I did quite a lot of visits and time. I was up in Akita and up in Tohoku, in Sendai. It's much stronger there. Because in prefectures where you've only got one medical school, they absolutely dominate the system. And the explanation that Tohoku University gives for why Miyagi-ken had the lowest number of infections and deaths from the pandemic is completely because of the ikkyokisei. Because they say that the dean of the medical school at Tohoku University was able to tell everybody where to go and what to do and how many patients to take because they were all graduates from his university, and therefore they couldn't come back if they didn't. So I agree with you in Tokyo because you've got so much choice. People have got much more freedom. But I think when you get outside that to those prefectures with one medical school, I was just surprised how strong it was.
Yeah, there's also a difference between national university and private
Yes,
universities.
completely. Yeah, yeah.
When I'm a graduate of national universities, I can only think of 3 classmates who are sons of doctors.
Yeah.
Out of 120, so.
Yeah, and if somebody can explain, that's absolutely true. And I don't fully understand that why. Because the same at most of the top national universities, there's very few who go on to run. They mostly want to go into research and things like that, yeah.
Thank you very much for your fascinating presentation, Professor Goodman. My name is Lina. I teach here at Temple in the economics department. You began your presentation by stating that Japan has both a population in very good health and an excellent health system, emphasizing that the two don't always go hand in hand. So my question is, in your assessment, and in the case of Japan, of course, to which extent could we attribute the good health of the population to the high quality of the health system, looking at causality?
You're the economist. I could talk about the rhetoric. I can talk about people's perceptions of it. And I think in general, people in the healthcare system believe because of the work they do that people have a good health outcome, because why wouldn't you believe that if you're working in the system? I think there are other people who are more skeptical. They think that there's a danger of too many tests. There are too many interventions. There are too many drugs that are given, even if the drugs are very weak. That it's too easy sometimes to get treatment, that perhaps you could wait and see what would happen. Who knows? I mean, you know, in the pandemic, what was it that led to different outcomes in different countries? One of the key variables probably was obesity, because that probably explains the much lower death rates in many less developed countries. And it probably the very, very high death rates in 1 or 2 countries with high obesity rates. That doesn't get talked about very much as a key variable. People talk about their systems, their interventions, their ventilators, and stuff like that. So, you know, Japan has a fairly non-obese society, although I'm sure everybody here knows Japan measures obesity in a different way, a different BMI figure in Japan than other countries. So elsewhere, universally, it's 30 is your BMI to be obese. In Japan, it's 25. The argument being that there are certain lifestyle illnesses that kick in Japan with an obesity level above 25 and below 30. The diet, of course, has often been seen as an explanation for why Japan is so healthy, but my goodness, that's changed. I've hardly been in Japan for 20 years, and I've been quite shocked by just how much fattier and more meat there is in the diet from 20 years ago. How difficult it is to get a fresh salad at lunch sometimes. So there are all sorts of explanations that you could say is to do with lifestyle as opposed to the system. In a way, I don't think well, does it matter? I think, give you an example, that I was offered free healthcare, check, right? The assumption is I'll take it. The letter I got from the Bunkyoku, it's almost a moral expectation. I'm not doing my part to protect the country by getting myself checked out, because I might then get cancer, which will then be a drain on resources. It's a very strong language in this. It wasn't an invitation. It was pretty much an instruction. And I think that's a slight problem with the health checks, is that you're kind of encouraged to spend as much as you can to get the top of the range. And of course, that can cause huge anxiety. If you go and check everything out, you'll find something. And that could lead to levels of anxiety, which may not be good for mental health. I mean, who knows? Who knows? I could go on for a long time. But the question is that the two are two separate variables, and the relationship is quite hard to check.
So I think we'd like to turn on to some questions on chat from the online folks. Yes, so I'll read off for those of you here. Okay, so the first question comes from David Satterwhite, TUJ faculty. Years ago, former Prime Minister Hashimoto, sorry. Okay. So David Satterwhite's question is, years ago, former Prime Minister Hashimoto, who had also been Minister of Health, who lost his Prime Minister position over raising the consumption tax from 3 to 5%, predicted bankruptcy of the health system. Your talk has been excellent on the micro level costs and incentives, including OECD comparatives. Even with a 10% consumption tax, what is your sense of the macro level viability of national health, all the more with the rising health costs for the elderly? Big question.
Okay, that's a brilliant question, and it's the thing that worries me most. My worry about the system isn't the current system, it's about the next generation. I can't quite work out how you're going to sustain the system for the next generation. Because you've already got the government subsidizing it at 35%, and as the population ages, two things happen. Your healthcare costs go up and your tax take goes down. So therefore, the proportion that the government's going to have to pay is going up. So you've only got a number of options. Your options essentially are to increase your tax rate, to increase your premiums, to increase your co-payments, or to reduce your service. Well, none of those are very popular at the moment with the electorate, and therefore politicians are going to be quite reluctant to do any of those. I mean, to be fair, premiums have gone up a lot in time over the last few years. Co-payments have gone up, particularly for under the LTCI. If you're elderly and your income is over a certain level, you can pay up to 30% and not just 10%. Of course, income, the VAT tax has gone up. So there have been some movements, but it's going to have to move much faster than that. And it's the thing that worries me, and this is real name dropping, but I've actually got a meeting with the current Takemi-san, the Minister for Health and Welfare, because I don't know the answer, and I wanted to ask him. And slightly to my surprise, he said, well, come and talk to me. I sent an email, and he said, come and talk to me. So I'm going to go and see him and ask him how he thinks the system will change over the next 20 years.
Yes, thank you very much for the great question and great response. Another question coming from Michael Shackleton. Am I right that Japan is also conspicuous for the lack of legal action against doctors or hospitals? Besides the relevance to Japan's medical system in general, etc., can this in any way be explained in terms of the family-run hospital? Interesting.
Yeah, I don't know about the connection between the two, but they're both, it's certainly true. Japan's level of medical litigation is relatively low, certainly by North American standards. But I would also say their level of medical intervention is also very, very risk averse. I've had 3 MRIs. Why? Because that's normal practice if somebody says they've got a slight dizziness, just to check out that there isn't something going on there. It would never happen in the UK because you wouldn't have the access. The investment hasn't been made. So doctors are very risk averse. They're very cautious. They give very low, they give a lot of drugs, but they're very, very low prescription levels. Strength. And one of the problems that some doctors I've spoken to who have come back from working in the States is they're just used to a completely different level of prescription of the drugs, the strength of the drugs that they prescribe.
Thank you very much. And I think I'd like to pass on to Joy Henry. You had your hand up for a while. Can you talk?
Yeah, I can talk.
Yes.
Hi, Roger.
Hi, Joy.
Great talk. A really interesting talk. I wanted to raise a couple of questions related to your comparisons between Japan and the UK. I've suffered from both of the things you've just described. And funnily enough, the vertigo one, feeling dizzy, also happened after I went to Japan and went away when I came back. So that and you were quite right, the GP identified it. He offered me a movement that could be administered, but I didn't do that, and it didn't go away. The other one, backache, I wanted to tell you what happened, because it's quite funny, because I got sent to an osteopath in Oxford. Not to an osteopath, to the osteologist, the doctor, first of all. And he said, how old are you? And I said, I think I was in my 50s at the time. He said, oh, well, then, what's your occupation? And I said, I'm an anthropologist. And he said, oh, well, then you'll know that
To the first one, that's a really interesting question about the use of complementary medicine. So I actually said to the orthopedic clinic doctor, after I'd been back a few times, what did she think about me going to see an acupuncturist? And her reaction was extraordinary. She actually burst out laughing, rather to the surprise of her nurse, because she's a very serious-looking lady. And so I was a bit surprised, and I said, would it cause any harm? And she said it would be a nice omiyage to take back from England. She thought it take back to England. It was a nice souvenir of Japan. And then I said, what do you mean? She said, well, there's no scientific basis, she said, for acupuncture. So she was absolutely, she said she didn't think it was going to do any harm, be a nice memory, but it was not scientifically proven. That's very interesting because, as I understand it, that's one of the things that distinguishes the Japanese system from certainly the Korean system, but also the Chinese and the Vietnamese system. So in Korea, which I do know quite well, if you're a Korean medical doctor, i.e. you're using Korean forms of complementary medicine, you first have to qualify as a MD, and then you become a KMD. So KMDs in Korea are at least as high status, if not higher status, as MD. They certainly are on exactly the same insurance structures, payments, and so on. And I understand that's quite similar in Vietnam and in China as well. Japan has gone right the whole hog from the Meiji period of totally embracing the Western form of medical interventions and not using the complementary system. Of course, there is complementary. I mean, you can see that also everywhere. But it's not covered. Very little of it is covered by the health insurance system here. Whereas in Korea, as I say, it's very much more is covered. Status of doctors, yeah, it's pretty high status. It's very high status, actually, I would say, compared to the UK. If anybody's been to see a doctor here, the language that's used, the politeness that's used by the staff and the patients who go in.
I think that's getting worse here, because nowadays when you go into a clinic or a hospital, you get told, or even when you telephone them, by the way, our practice doesn't accept abuse of any sort. So I suggest that possibly doctors and other medical staff are getting abuse for the fact that people have to wait so long, for example.
Yeah.
So it is in a bad way.
Yeah.
And thanks anyway.
No, you're welcome.
Yes.
Oh, by the way, the medical people here also think many alternative forms of treatment are non-scientific, therefore rubbish. But sometimes they're based on Chinese systems of science, for example. But anyway, it's another conversation we can have when you come back.
Yes, thank you very much. I think we're at 8, so we will wrap up. But I appreciate your excellent talk. If you could join me in hopefully Roger recovering soon from a health problem and not having to visit doctors again as a patient, that would be great. So thank you very much, everybody. Thank you very much.